Okay, everyone, we're going to go ahead and get started. Good morning and welcome. Thank you, everyone, for joining the VCU Medical Center Health and Wellness Library today for our couple day early Rare Disease Day program event. I am Dr. Dana Ladd, Health and Wellness Librarian at the VCU Medical Center Health and Wellness Library, which is a library for patients, their family members, and community. And we're located on the ground floor of the VCU Health Gateway building. Over the years, many patients and their family members with rare diseases have visited the Health and Wellness Library, seeking assistance in helping find health information about their diseases. Patients with rare diseases experience many barriers and challenges throughout their healthcare journey. A delayed or misdiagnosis, few or no FDA-approved treatments, lack of access to disease specialists, many financial challenges, and difficulty finding consumer-level health information about their rare diseases. And that's just to name a few of the many challenges and burdens faced by patients with rare diseases. Our library staff is dedicated to helping patients find reliable consumer health information about their health, including information about rare diseases. And as many of you know and have attended in the past, we provide an annual Rare Disease Day program. This year, we have a very special speaker, one who will share his experience with battling a rare disease and almost losing his life 5 times. It is with great pleasure that we have here with us today, Dr. David Fajgenbaum, to share his inspiring story. Dr. Fajgenbaum is an associate professor of medicine in translational medicine and human genetics at the University of Pennsylvania, founding director of the Center for Cytokine Storm Treatment and Laboratory, associate director, patient impact of the Penn Orphan Disease Center, and co-founder and president of the Castleman's Disease Collaborative Network. He is the national best-selling author of Chasing My Cure, A Doctor's Race to Turn Hope into Action. And he is a patient battling a rare disease, idiopathic multicentric Castleman's disease. Dr. Fajgenbaum co-founded the Castleman's Disease Collaborative Network in 2012 to accelerate research and treatments for Castleman's disease through a collaborative network approach, a business-inspired approach to biomedical research, which has become a blueprint for advancing rare disease research. He is also dedicated to advancing drug repurposing as co-director of the advisory committee for an FDA NIH CPAP public-private partnership called the Cure Drug Repurposing Collaboratory, and lead investigator for a collaboration with the Chan Zuckerberg Initiative to advance rare disease drug repurposing. He has been profiled in a cover story by the New York Times, as well as by Good Morning America, CNN, Science, Reader's Digest, Forbes 30 and Under 30, and the Today Show. Dr. Fajgenbaum received a Bachelor of Science in Human Sciences with distinction from Georgetown University. He studied for a Master of Science in Public Health from University of Oxford as a 2007 Joseph L. Britton Scholar. He earned his medical degree from the Raymond and Ruth Perelman School of Medicine at the University of Pennsylvania, and he received his MBA from the Wharton School. And I want to add, Dr. Fajgenbaum works tirelessly to improve the lives of patients with Castleman's disease and also those with other rare diseases. Patients and their loved ones with Castleman's disease are forever grateful and thankful for his dedication and all he has done to find cures for all Castleman's disease patients and to improve the quality of life for those affected by this disease. I welcome Dr. David Fajgenbaum. Thank you so much, David, and I'm going to turn the mic over to you.
Dana, thank you so much for that introduction. I've known Dana for many years, and I just so appreciate those kind words. And I'm just so happy to be with you all today. I wish that we were all in person, but as you'll hear from my story, just being here is important, and being with you all really means a lot to me, especially as Rare Disease Day approaches. You all probably may be aware that Rare Disease Day is technically February 29th, but in years, because that's the rarest day of the year, but in years where there is no leap year, then we celebrate Rare Disease Day on February 28th. So as Dana said, we're closing in on Rare Disease Day, and it's really just such a pleasure for me to be with you all today to share my journey. I'm going to share my screen, and today I plan to share about my journey chasing my cure. I'll share about my journey chasing cures for other patients, and then also lessons that I've learned along the way in this effort to find treatments for myself and for others. In August of 2010, I was a healthy third-year medical student, training to become an oncologist in memory of my mom, who had passed away just a few years before, when out of nowhere, just within a matter of weeks, I became critically ill myself with multi-organ failure. My organs were shutting down for an unknown cause. Over the next several weeks, I experienced progressive organ failure. A retinal hemorrhage made me blind in my left eye. I gained 70 pounds of fluid and drifted in and out of consciousness. I needed daily transfusions just to keep me alive. And after weeks and weeks of this with no answers, a priest eventually came into my room and read my last rites to me, because the doctors were certain that I wouldn't survive. And I've really considered that moment when a priest was in my room reading my last rites to me to be the start of my overtime, time that I didn't think that I would have, where I've really tried to make the most of every second. And really, thankfully, just in time, the diagnosis was made. As Dana mentioned, idiopathic multicentric Castleman disease, which is a rare disease where the immune system becomes activated, attacks, and then shuts down your vital organs for an unknown cause. There are about 5,000 patients diagnosed each year in the US, which makes it about as common as ALS. For my subtype, about a third of us will die within 5 years of diagnosis, and another third will die within 10 years of diagnosis. Unfortunately, at the time, there were no FDA-approved therapies. So I was given a combination of 7 different chemotherapies that my doctors hoped would maybe save my life in a last-ditch effort, and they did, thankfully. And my dad didn't leave my side. In this picture, you can see my dad next to me. This is actually about 5 months into my illness, and you can see that the chemotherapy has made me bald. I've got a big belly because my liver and my kidneys weren't working, but I was just so glad to be alive. I mean, to give you a sense for how sick I was, I actually felt better with every single dose of chemotherapy that I received. So with the chemo, I started feeling better. And the picture on the right of the screen is from New Year's Eve 2010. My dad and I decided to take a walk around the hospital. So now this is about 5 months from when I first got sick. And as we passed the family waiting room at the hospital I was at, we noticed that there was a gentleman who'd clearly been drinking on New Year's Eve. He was like visibly drunk, and he fell onto the ground. And so my dad ran over to him and helped him back into his chair. And he looked at my dad and I, and he said, "Thanks so much. Good luck to you and your wife." We said, "Wife? What is he talking about?" And then I looked at my belly, which was distended from my liver and kidney failure, and I realized that he thought that I was my dad's pregnant wife, which was a low point emotionally for both of us, but we really managed to laugh so hard. And we've learned along the years that laughing in the midst of tough times is really, really important. So from this picture, you can kind of see how someone maybe would have confused me as my father's pregnant wife. And then this picture is just from a few years before, when I played college football at Georgetown. I was a quarterback there. And I always say these are the worst before and after pictures of all time. But if we could flip the order, it could be this great advertisement for Peloton or for Muscle Milk. But unfortunately, the pictures are in the wrong order. Now, I did take a picture every week for the next 8 weeks, and you can see my hair starting to grow back, and you can see my belly starting to shrink away. I look less like my father's pregnant wife by the end of those 8 weeks. And when I got out of the hospital, there really were 2 things that kept me going. The first is the love of my life, Caitlin, who I dated for the previous 3 years, and I dreamed of one day having a family with. And the second is in this pack that's over my shoulder. I was receiving an intravenous experimental drug every 3 weeks that we hoped would keep my disease in remission. It was the only drug, or it is the only drug that's ever gone through a large phase 2 clinical trial for Castleman disease. And like every good patient, I trusted my doctor, and my doctor believed that this drug was going to keep me in remission. This experimental drug would work. And I hoped with everything I had that it would. So I went back to medical school. But unfortunately, about 1 year later, I relapsed while on this drug. And what was so difficult about this is that I learned that I was now relapsing on the only drug in development for my disease, for Castleman's. I learned that there were no more drugs in development. There were no more even promising leads. And that I was also approaching the lifetime max of my chemotherapy. So thankfully, you can see in the picture I got chemo again, the same 7 chemotherapy drugs, and thankfully they worked and they saved my life. But I knew that if I wanted a future, that I could no longer just hope that some doctor somewhere found a drug for me. I would need to get involved in searching for a treatment that could maybe save my life, even if it was unlikely that I would actually be a part of finding one. And so I turned to my dad, my sisters, and Caitlin, and I said, I'm going to dedicate the rest of my life, however long that may be, to trying to find a drug that could maybe help me and patients like me. So the first thing I did was to find some space at Penn to begin to conduct laboratory research. But I knew that as a medical student, it was unlikely that I was going to make enough progress to actually be able to help myself or really anyone else. And so I started an organization called the Castleman Disease Collaborative Network to really drive forward the science. And I quickly learned that very little progress had been made in the previous 50 years. There was no diagnostic criteria, no treatment guidelines, no research community. And the discovery that led to the treatment that I'd been on previously, that experimental drug, was made 25 years before, and there had not been a single discovery like it since then. So we didn't know what else to potentially target with a drug. And so I knew that if we were going to take this disease on, we had to do things very differently than they had been done in the past. And we did. To start, number one, we wouldn't just raise money and then invite researchers to apply to use it how they thought it should be used, which is kind of the traditional model where you hope the right researcher applies for the right project at the right time. We would actually build a community of physicians, researchers, and patients, crowdsource from that community what research studies should be done, and then recruit the best researchers from within Castleman's and outside of Castleman's to actually do our studies to drive it forward. And secondly, we knew that if we could figure out a potential target or mechanism involved in Castleman disease that a drug could go after, we knew that we didn't have the time or the resources to develop a drug from scratch. We knew our only option would be to look for drugs that already existed that could maybe be repurposed to treat Castleman disease. So what do I mean by this idea of drug repurposing? Well, first off, there are about 10,000 human diseases, and there have been about 2,500 drugs developed by humankind to address these diseases. And most drugs are approved for between 1 and 2 different diseases, and many diseases have multiple drugs approved for them. So in total, there are about 2,500 drugs that are approved for about 2,500 diseases. Unfortunately, that means that there are about 7,000 diseases that don't have any FDA-approved therapies. Now, the good news is that many of these diseases that don't have therapies share common mechanisms or susceptibilities to diseases that do have drugs. And so in some ways, and in many ways, these drugs can actually work across additional diseases. But unfortunately, there are very few incentives in place to figure out additional uses for already approved drugs, especially drugs that are already generic. But of course, I didn't care whether a drug was generic or not, and I certainly didn't have the time to wait for a new drug to be developed, which often costs about $1 billion and takes about 10 years. So I knew that my only hope was that maybe one of these drugs that's already approved could actually be the right drug for my Castleman disease. And this idea of drug repurposing is not unique to medicine. In fact, the first telephone was actually intended to be a hearing aid. The first radio was intended for ship-to-ship communication on the open seas. And the first computer was intended to track results from the US Census. Similarly, thalidomide went from being a birth defect causing morning sickness drug to being a myeloma killing cancer drug. The drug Viagra, which many of us know the intended use initially, has now also been found to be effective for a very rare pulmonary disorder. The drug tocilizumab was actually developed for Castleman disease, and though it didn't work for me, it is now the first drug that is used in the ICU for patients with COVID-19. It's also used for rheumatoid arthritis as well. And finally, aspirin went from being a pain reliever to also being a heart disease preventer. Unfortunately, these are the exceptions as opposed to the rules. And as I mentioned earlier, about 90% of all approved drugs are already generic. So there are no companies that are incentivized to figure out additional diseases or uses for already approved drugs. And so that really kind of begs the question, why is healthcare the only industry where the first use is often the last use, and we haven't fully utilized the potential for drugs to treat diseases, particularly rare diseases? So with this in mind, we got to work. We developed the first diagnostic criteria for Castleman disease. We developed the first treatment guidelines. We assembled a community. We started driving with the science. And in parallel, I graduated from medical school. Caitlin and I got engaged to get married, and we had this wedding date, May 24th, 2014. And I enrolled in business school because I realized that some of the greatest challenges in the way of progress were organizational challenges. And I wanted to develop the skills to efficiently and effectively advance drugs towards cures. But unfortunately, in the midst of all of this, I relapsed and I nearly died now for the 5th time. I spent another month in the hospital in critical condition with all of my organs shutting down. Again, I got chemotherapy. And again, thankfully, chemotherapy saved my life. But at this stage, I've reached my lifetime maximum of chemotherapy. And I knew that I wouldn't make it to May 24th, 2014, unless I found a drug that could maybe help to keep my disease in remission. So as soon as I got out of the hospital, fortunately, I had been storing samples on myself, blood samples, and even a lymph node sample in the weeks leading up to my relapse. So that way I knew that if I were to survive, that I would want to be able to utilize these samples for research purposes. So I did a series of studies on my samples where I found that a number of cytokines or growth factors were highly elevated in my samples. I also identified specific cell types and pathways that seem to potentially be involved. And maybe most excitingly and importantly, I discovered that a particular communication line in the immune system called MTOR seemed to be highly activated. And it was possible that maybe MTOR was involved in all the things that we were seeing that were leading to my Castleman disease. And so I wanted to do an experiment to demonstrate whether this was the case or not. And so I did a really simple and cheap experiment where I measured the amount of activation of this particular communication line. And in this normal lymph node, you'll see brown is positive and blue is negative. And so you can see in a normal lymph node, there are some cells that are positive for having this particular communication line turned on. There's some cells that are brown, but most cells are blue. And then we looked in my lymph node and we were just blown away by the tremendous amount of activation of this particular communication line. I mean, it was just blazingly positive. And so this confirmed to us that this particular communication line, which is involved in a lot of aspects of the immune system, seemed to be stuck in the on position for most cells in my immune system. And so we wondered, could inhibiting it maybe be an effective treatment for me? Well, fortunately, 50 years earlier, researchers had uncovered a compound that we call sirolimus in the soil on the island of Rapa Nui. And they figured out that that particular compound was really good at inhibiting mTOR, that particular communication line. And it went on to get approval for kidney transplantation. It prevents rejection of kidney transplants. But no one had ever even imagined that it might be useful for Castleman disease. And here I was 50 years later, with data in hand that suggested that maybe this drug could be utilized in a new way to treat my Castleman disease. And I shared this data with my doctors. And since we really had no other options, we all decided that we should try it. And I became the first patient with my disease to ever receive sirolimus. And today marks 97.68 months that I've been in remission on this drug. And now I say 97.68 months because I know that I can't round up. I don't know if this drug is going to work for 98 months, but I also refuse to round down. I'm so thankful for every fraction of a week, a month, a day, a year. When you look at this graph, you can see that my previous remissions on average all lasted less than 10 months. And here we are, closing in on 100 months. But of course, I know that I can never round up. During this remission, the New York Times called this "Doctor Cure Thyself," which I think is a bit of an overstatement. I think it should be doctor helping himself a little bit right now and hopefully for a lot longer. But I don't think that would have fit on the headlines. But really importantly, Caitlin and I made it to May 24th, 2014. We made it to our wedding date. My hair grew back just in time for the wedding pictures, which was pretty important. And then 3 years ago, we welcomed our first child into the world, our sweet Amelia, and just 3 months ago had our second child. And it just feels like a dream to think that where I was in the hospital and all that I went through for months of being hospitalized to now have a family that I'd always dreamed of and to have such an amazing wife and kids. It just doesn't feel real. During this remission, I also joined the faculty at Penn, where I launched a center called the Center for Cytokine Storm Treatment and Laboratory to try to do what we've done for me for other people. In the same way that that life doesn't feel real, how many more patients can we create a dream reality by finding a drug that maybe is hiding in plain sight for them? When sirolimus, when it first became clear that this drug was helping me, we started giving it to other Castleman's patients without options. So patients like Katie and Deepa, Clara, Jacob, and Joey, who were not responding to existing therapies. They all responded really, really well to sirolimus, and it's hard to put into words just what it meant when these patients and others began benefiting from this drug. But unfortunately, it hasn't helped everyone. But we've thankfully been able to apply the same approach that we took to find sirolimus for me to find other drugs. And so when I got a phone call from Kyla's from Kyla's doctor, saying that she wasn't responding to anything, IL-6 blockade, sirolimus, chemotherapy, nothing was working. She'd spent a year in the hospital. We suggested that she try a drug called ruxolitinib, which was developed for a form of cancer a few years before. But in our lab, we thought that it could maybe be helpful for Castleman disease. And Kyla has been doing really well now for almost 2 years. It's this sort of effort that has led to these patients and others like them being alive. They frankly would not be alive if we had not discovered these drugs and new uses of old drugs to treat them. And we did this through raising and investing about $1.8 million into Castleman disease research. And fortunately, that led to an additional $12.4 million in investments from other organizations outside of the CDCN. So there's about a 7 times return on investment for every dollar that we spend on research. About 7 times that is spent by other organizations because we spend our money really wisely. And of course, there's sort of an incalculable impact on patient lives through our work. But we've also looked beyond Castleman disease. When my uncle was diagnosed with metastatic angiosarcoma and told that he had no more options and that he had just a few months to live, we got to work following the same approach. And we found, in fact, that his tumor seemed to be susceptible to a cancer immunotherapy. And my uncle became the first patient with his form of cancer to ever receive a checkpoint inhibitor. He's now been doing well for over 5 years in remission. And now patients all over the world are using checkpoint inhibitors based on this initial finding. But unfortunately, no matter how hard we try, we are not able to help everyone. Patients like Lisa, Elise, and Joseph have passed away battling their disease despite us trying everything we possibly could. And right now we can help about half the patients that we try to help through the work that we're doing, but the other half of patients really motivate us to continue to push forward our work for Castleman disease. And that same motivation has driven us to launch the Corona Project when COVID-19 emerged, to try to apply our approach from Castleman disease to COVID. And with support from the Parker Institute, we've built the world's largest database of treatments for COVID-19. And we've applied an algorithm across data from over 270,000 patients, 600 different treatments, to identify what drugs appear to be most promising to least promising. And really incredibly, the 2 drugs that have likely had the greatest impact on lives saved are a drug called dexamethasone and tocilizumab. Both of them are repurposed drugs that are both quite cheap. And tocilizumab actually was initially developed, that's the drug I mentioned earlier, that was initially developed for Castleman disease. So really incredible to see the lives saved during COVID with repurposed drugs. And we've also used the Corona Project data to identify the most promising drugs for the NIH's $150 million active 6 study. This served as the evidence base for that research. So as someone who was alive because of this approach and someone who has seen it repeatedly help more and more patients, you can imagine that I am just fully committed with everything I have to trying to figure out more ways that we can identify the full uses of all available drugs. And so how do I think we can do this more? And I think given the work that you guys all do as a health sciences library, I think that many of these things will really resonate with you, and I hope you'll be a part of this. So the first is that we have to raise awareness about the potential for drug repurposing. And I wrote a book called Chasing My Cure about my journey, and that's helped in some ways to raise some awareness. In fact, I got a call about a year ago from former President Clinton that he had read Chasing My Cure. And the one thing out of the 200 and however many pages that really stood out to him was this idea that drugs could be repurposed further than they are. And of course, this is something similar that I've heard from other readers as well. And I think that Dana actually has arranged for some copies of Chasing My Cure to be made available to some of the participants today. Of course, you can get a copy anywhere that books are sold and anywhere you like to buy your books from. Secondly, we realized that we could not just hope that sort of people would figure out how do you get from point A to point B, and that we would need to map out the process, the roadmap for drug repurposing. And so about a year and a half ago, we launched the Roadmap Project to map out how do you repurpose drugs? What are the paths that you can go along to repurpose drugs? And finally, I believe that we need to build the sort of data engines and systems to be able to leverage all of the data available to us in the same way that we did for Castleman disease and for COVID, to figure out what other repurposing opportunities are there. I mean, we realize that there are very few people incentivized to do this, but can we harness the data being made available to us, especially with new technologies like next generation sequencing and proteomic technologies? Can we harness all of that data to intentionally look for new uses for existing drugs? And can we imagine a future like this, where those 2,500 drugs and every year there's about a dozen more that are added, that we can have an impact across so many more diseases? And with Rare Disease Day coming up, I think it's important to note that among those 7,000 diseases that don't have treatments, 95% of them are rare diseases. So, it's the rare diseases that really don't have treatments. And it's this long tail of diseases that really need additional work and need more therapies. So I want to close with a handful of lessons. And then I think that Dana and I are going to spend some time taking questions. And but I want to spend a little bit of time on some lessons. And so first off, I deeply wish that I had not gone through what I did, and that my family didn't have to go through what I've gone through. But in the process, I learned so many lessons about life and about hope that have really fundamentally changed who I am. And that's why I wrote Chasing My Cure, is to share those lessons more broadly with other people, so that you don't have to go through what I went through to learn these lessons. And so I'll just start out by sharing a handful. The first is that at the beginning of my talk, I mentioned this idea of feeling like I'm in overtime. Well, the reality and what I've learned is that we are all in overtime, and we all need to make the most of our time, because none of us know how much time we have. The second is that I hope no one watching this is ever confused as their father's pregnant wife. But if you are confused as your father's pregnant wife, I hope you can find some humor in that and all of life's challenges. I've found that laughing with the people you love can just be incredibly powerful during really tough times. The third is that we have to turn our hope into action. Everything in my life changed when I went from hoping that someone somewhere would figure out something for me to realizing that if I'm going to hope for it, I should take action for it. And no matter what that is in your life, just reflect on what you're hoping for, you're wishing for, you're praying for. Whatever those things are that you're hoping, wishing, or praying for, those should be the things that guide your actions and should drive forward on how you spend your days, how we spend our days. The fourth is that solutions may be hiding in plain sight. The drug that I'm on was sitting at my neighborhood pharmacy for years while I was in and out of the ICU, and no one knew that it could be a solution for me. How many drugs are sitting at your neighborhood pharmacy that could be a treatment for you or for someone you love that we just don't know about yet? And I think that data science and using information through health science libraries, this is where the information is hiding in plain sight, and figuring out ways to pull it out and to gain insights from the incredible amounts of data that are being generated. And finally, the fifth thing that I want to share is that my book is called Chasing My Cure, but I really think we should have called it Chasing Our Cures, because it hasn't just been me chasing my cure. It's been this incredible team of people working together to find solutions for Castleman disease, for COVID, and for so many more diseases. It's really been an army. And I hope that all of you will be a part of that army. I hope you'll help to raise awareness about the work we're doing, about this journey, Chasing My Cure, and that you'll join us. When you think about major challenges like we're discussing today, these require major collaborative efforts. And so if you're involved in biomedical sciences, if you're a rare disease patient, if you're in medicine, I hope you'll reach out to me. I've got my email address on the screen. I've got my Twitter handle at the bottom. I hope you'll join us in figuring out ways to, as we said, raise awareness, map out the process of drug repurposing, and finally build the kind of systems needed to find drugs that could be repurposed. Because, as Dana shared at the very beginning, there are so many individuals with rare diseases. In fact, there are 7,000 rare diseases that affect 30 million Americans. And as Dana shared, 95% don't have a single approved therapy. And so we've got a lot of work to do for rare disease patients, but I think that if we work together, though none of us can round up and all of us are in overtime, I think we can really make an incredible difference in terms of finding additional therapies for patients with terrible conditions. So I'd be just totally thrilled, Dana, if you want to come on and share any questions that are in the chat or any questions that come to mind for you. But yeah, thank you all so much.
Great. Thank you so much, David, for sharing your inspiring story with all of us. And like David said, please feel free to go ahead and type your questions in the Q&A panel as well. And also, just wanted to let everyone know, David mentioned his book, Chasing My Cure. So stay tuned. After the Q&A session, we are going to have a door prize for a free copy of Chasing My Cure. So that's really exciting. And also stay tuned. We'll be sending out emails probably over the next few weeks. We also want to hold a book discussion of Chasing My Cure. So be on the lookout for that as well. So while folks are typing their questions into the Q&A panel box, I just have a question to get us started with our Q&A session. So David, you have experience with rare diseases from a very unique perspective. That is a patient and also a healthcare professional. What are some of the most important things patients or family members of patients with rare diseases should know when navigating their healthcare journey with a rare disease?
Such a great question. I think that the first thing that comes to mind is how important it is to find an expert. With a common disease, there is probably dozens of doctors in your area that are going to be experienced treating that disease and caring for it. But when it's a rare disease, there might be a dozen qualified doctors in the whole world. And so it's really critical you find those. You find a doctor, and I often say, it seems overwhelming to try to figure out a new doctor because you might have someone local that you really like and they seem like they're good. But if you can just get in your car and you can drive, however long that drive is, hopefully it's less than 12 hours. But if you can just get in your car and just start driving, finding an expert doctor, I think is really, really important. That's number one. I think number two is that I've learned that doctors, we do the best that we can, but we aren't always right. We make mistakes. We forget about things. We don't see things. And so as the patient, I think we expect our doctors to kind of do all that stuff and to stay on top of it. And doctors should. We certainly should do our best. But I think as a patient, we have to realize that sometimes it's okay to follow our gut. It's okay to follow our intuition. If we're worried about a symptom or a lab test or something, and our doctor's not worried about it, it's okay to push and say, hey, should we repeat that? I've been feeling a little unwell. It's important to advocate for yourself. And that can often be a tough thing to do because sometimes patients feel uncomfortable pushing their doctor one way or another. But I think it's important to find an expert and then to have a really active relationship in your care where you can make sure that the doctor's listening to your concerns. And then I think the third thing I'd say is to not underestimate the power of the caregiver. For a lot of rare diseases, particularly ones that affect children, the caregiver is very much the person who is sort of the driving force behind making sure that patient's getting to all the right doctor's appointments. And the caregiver is so, so important. So I think those are the kinds of things that I would mention is if you're a caregiver versus being the patient, recognize, the power that you have and the important role that you play. And sometimes it's an underappreciated role. Of course, you do incredible work and maybe you don't get the recognition that you deserve, but it's so, so important.
Yeah, great. Thanks, David. Those are terrific advice for
Absolutely.
Patients, and also to, let folks know too, the Health and Wellness Library can help patients find specialists who treat rare diseases. We can help with that. And we also have a lot of, David mentioned how important the caregiver is in this role.
Yes.
And often a lot of rare disease patients are young children, and their parents are taking care of them. And we have a lot of resources in the library for caregivers to help them through that tough role of parenting a child with a rare disease and helping them with that process too. So thanks, David.
Yeah,
and,
Dana, I'm just going to make a quick comment to say
yeah,
I'm seeing all these questions in the Q&A in the chat, and I just love them. So sorry, I just want to make a comment to say I love all these wonderful questions and eager to get
yeah, it is. I'm so great. I'm so thankful that people have a lot of great questions. So yeah, so one of them from the Q&A panel is this similar to what is going on in the ALS community, and and I'm not sure how to pronounce this.
Synapticure.
Synapticure following your model.
So I know the ALS community, I'd say very, very well. And unfortunately, the reason I know them so well is that my brother-in-law was diagnosed with ALS about 7 years ago, and he passed away 2 years ago. And so I know the world very well because we've lived through it in my family. ALS is such a blessing of organizations and resources being directed at it. And there are amazing ones, including Brian Wallach, who's an amazing leader, and Brian's launched Synapticure. ALS is slightly different from Castleman disease in a couple ways. One is that there are a number of organizations that are all focused on ALS treatments, and they're all kind of thinking about it from a different angles. Whereas in Castleman disease, there was this vacuum. There really wasn't any research organization when we started, which meant that we were able to kind of build the right solution for the field. Whereas in ALS, there's oftentimes a lot of sort of turf wars in some ways in terms of how to push things forward. And it's because everyone cares so much. If you have a loved one with ALS, you literally would do anything in the world to end their ALS. And as a result, that can create some competition or at least conflict. Which is something you see across the rare disease space. Synapticure is an awesome effort. From what I understand so far, Synapticure is particularly focused on bringing patient care to the home, so that way you can do virtual visits with your ALS doctor. I can tell you from firsthand experience with my brother-in-law who was so sick with ALS. Trying to get him to doctor's appointments towards the end of his life is really, really tough. So I think Synapticure is more focused there. But Brian's entity and his work, I Am ALS, is just very similar to what we're trying to do. And he's a good friend and a role model of mine.
Great. Yeah, thanks, David.
Sure.
And I was hoping someone would ask this about COVID as well. So how have you personally been dealing with COVID, being immunocompromised? I ask as someone with lupus taking repurposed drugs to manage it.
Yeah, great question. Like I said, these questions are really wonderful. So yeah, I'm very immunocompromised because that's the purpose of my drug, right? The intention of the drug is to compromise my immune system, to suppress it, so that way my Castleman's is under control. And as a result, that puts me at risk of COVID. And so my family and I didn't quite live under a rock, but we lived a life as close to living under a rock as you possibly could have during the first probably year and a half of the pandemic. We really just were completely isolated, which of course we all know the challenges that come with that. But we were really scared. I mean, I was frankly just very afraid. Not only do I have a suppressed immune system because of treatment, I also have an immune system that is known to get highly activated and to get flighty. And so I was very concerned. we really were very precautious, particularly early on. And I ended up getting vaccinated quite early. And I, went back and forth. And from looking at all the information, it seemed like it was the right decision. And now there's some pretty good data that suggests that it was the right decision. So I did that. And, for anyone who's immunocompromised, you should be aware that if you get COVID, the first thing you should do is try to get a drug called Sotrovimab. It's a monoclonal antibody that is incredibly effective. It's over 85% effective in terms of preventing hospitalizations and poor outcomes. And so, yeah, I mean, the good news is that there are drugs that are out there. So Sotrovimab is really great at preventing hospitalizations. Dexamethasone and tocilizumab are very good once you're hospitalized. But unfortunately, there hasn't been a lot of attention on the really effective drugs. There's been a lot of attention over the last couple of years on drugs that aren't as effective because they've been sort of hot button emotional topics, but actually that's meant that people haven't focused on the drugs that are really effective. And so I think that a lot of people who could have benefited from the effective drugs have unfortunately not gotten them.
Yeah, well, thanks. That's definitely important for those who are immunocompromised to know about those drugs. Thank you. And our next question is, I'm interested in the process of writing, publishing, and advertising your memoir. I would like to write a similar book. I have hypermobile Ehlers-Danlos syndrome.
Well, first off, I'm sorry to hear about your EDS. But yeah, my process was, I think I would say, a little bit non-traditional in that I had never thought about writing a book. And that New York Times article that I shared a picture of, the New York Times article ran in February of 2017, so 5 years ago. And it was read really widely. It got a lot of attention. And in doing so, it got the attention of a number of book publishers. So book publishers actually look out for stories. They try to find things in the news that look like they should turn into books. And so I was contacted by a number of publishers and ended up really spending a lot of time reflecting on whether that was the time to write a book or not. As the title of the book is Chasing My Cure, because we haven't found the cure yet, right? I'm on a drug that's helping me, but we're still chasing it. And so writing a book by definition is going to take a lot of time. And so reflected a lot and felt that given how much I enjoy speaking and sharing lessons through venues like this, that I thought writing a book would be a great opportunity to do that. And so decided to do it. The first step is to find a really good agent. Literary agents are really hard to come by, or at least really good ones are. And so I got lucky, got a really great literary agent. And then we put together a book proposal first. You share the book proposal with different publishing houses. And then you hope that one of those publishing houses picks your proposal and agrees to work with you. And then you go down the road of writing it. And writing it is really I'd say almost the easy part. Once it's written, and it's not easy, but once it's written, then trying to raise awareness and get the word out is not easy, especially given that there are so many other newsworthy sorts of things. But it really, that's kind of the process. And I'm really happy that I did it. I'm really, really happy I did it. Yeah, I really enjoyed reading it. It was a terrific book. I hope everyone joining us today gets the opportunity to read David's book. Thank you.
And we have a comment. I'll read you the comment. It's thank you for a very interesting presentation and good luck in coming years.
Oh, thank
and our next question is, do you know for Castleman's disease, which drugs might work for which patients?
Yeah, so we're starting to try to figure that out. There's one drug that experimental drug that I was on that didn't work for me. That went on to get approval. It's effective in about 1/3 of patients. And so that's a big step. We're lucky. Castleman's, now have an FDA approved drug, which is pretty awesome. We have done some research to try to figure out which patients are most likely to benefit from that drug. And we just published a paper a few months ago where you could measure 7 different proteins in the blood and get a pretty good idea to predict whether siltuximab is going to work or not. You can do that before you give treatment and predict whether it'll work. We also have another paper under review right now where there's a particular protein called CXCL13. You can measure the levels of it after you give siltuximab, and if it goes way down, then you're likely to benefit. If it doesn't go way down, you're not likely to benefit. So we're trying to tease out, who's going to benefit, who's not from that. And then people who don't benefit from siltuximab, it's just really hard to know what the right next drug drug is. I mentioned sirolimus, which is the drug that I'm on. I mentioned ruxolitinib, which is the drug that that's kind of the next generation of a drug that we've found. But no, we're still trying to work that out. And knowing who's going to respond is really important because many of us get really sick really quickly. And so you don't really have time to kind of just try a lot of drugs and see what works. You really need to be intentional about it.
Okay, great. Great. Thanks, David.
Mm-hmm.
And another question is, how might we better integrate academia and the pharma industry to push novel drugs and discoveries through the pipeline faster?
Yeah, this is in my opinion, $1 million question. I think that you all who work in academia know that academia and industry are quite sort of separate. There isn't all that much interaction between people who develop drugs in the pharmaceutical industry and people who search for maybe new drugs and do research in the academic world. There's some pretty big divides. And I think we got to figure out a way forward. I don't have a great idea for how to do it. But we've got to figure out a way forward because, academics, we can't develop drugs without companies, and companies, can't get ideas for, drugs to develop without academics. And so I think we got to figure out a way forward. And I think part of it is going to require patients really driving that conversation because no one is incentivized like we are to bring people together. And I talked about, the problem with drug repurposing, which hopefully it came through, is that there are a lot of links that already exist, but there are no incentives to actually make those links or bring those links together. So it's like data's out there to suggest that this drug might be helpful for that disease, but there's no incentives because there's no companies when a drug's generic that will be able to sell that drug and make money off of it to really do the studies to prove that that link is real, because it's actually very expensive to do big clinical trials and to prove the drugs work. And so if the company isn't going to make any money after they get the drug approved for a new use, then they can't justify spending tens or hundreds of millions of dollars to do a trial. So we got to figure this out somehow. And I think that it's going to be some combination of the federal government helping in some way. I think it's going to require academia and pharmaceutical industry to work together, but it's not an easy problem.
And a comment and a question. Thank you is so insufficient to express my gratefulness to you for sharing your inspirational story. Would you share the resources you found most helpful to instill hope, clarify vision, and create the energy and fortitude to take action?
This is going to sound really cheesy as a response, but I learned a lot from my journey that I didn't have a resource. Like there was no guidebook, there was no sort of resource. And like I said, this is going to sound cheesy, but I actually wrote all of those things down that I learned in chasing my cure. And so that's really what that book is it's just the thoughts, the ideas, the actions, the hope, the inspiration that actually got me through it. So again, it's a cheesy answer to say like, my book has the answers, but it's the truth. Because I did spend a lot of time reflecting on what were the things, because what I didn't share as much today were all of the low points. There were a lot of low points in my journey. There were times when I wanted to give up, when I didn't have the strength to keep fighting, but of course I found it because I'm here today. So there were ways that I was able to get through the tough times, but they weren't easy. They were really hard. And so yeah, I would encourage you to check out Chasing My Cure, because I do think that there were just a lot of things that I didn't know before I went through what I went through, and that I wanted to share externally.
And someone else would like to know, is Castleman's disease inherited?
We don't know that yet. What we do know is that somewhere between 1% and 5% of all Castleman disease patients do have a family member who has Castleman disease. And so for at least that 1% to 5% of patients, I think we can feel pretty comfortable thinking, considering it's inherited. But for the other 95+% of patients, we know that there's not another family member with it, but that doesn't mean that there's not a genetic component, because there are genetic mutations that are called de novo, which means that that you don't inherit them, but that they occur in basically in your conception. So it's still a genetic disease, but it's not necessarily inherited in the way that we think about it. So we're doing a lot of work trying to figure out the role of genetics in Castleman disease. I mentioned it's idiopathic, meaning we don't know what causes it, but that's where a lot of our research is focused, is trying to figure out what is it that causes IMCD.
And I think we have a few questions in the actual chat box. So let me See, because we have a few more minutes.
Sure.
Here's
Yeah.
one.
I just love all the questions, Dana. Usually I
Yeah,
make my talk longer, but I thought today I would make it shorter, and that's a risk, right? Because then you don't know if anyone's going to ask any questions, but it
that's
certainly
right.
was the right decision because these are just wonderful questions.
Yeah, lots of great questions. Thank you, everyone, for posting your questions. So we have one here. Is there anything from your journey that you think can be included in the medical school curriculum to get students thinking about these issues?
Yeah, I think the number one thing is that in medical school, you're not taught what's not known, right? Like the answer is never, if you have a multiple choice set of answers, the answer is not like no one knows, right? So the problem is that in medical school, you teach all of the diseases, all the drugs, all the mechanisms that the medical community has figured out, because it's hard, again, to ask a question where the answer is like, no one knows. So as a result, medical doctors come through when we're done with our training, we believe that like there's an answer for everything because everything we've ever been asked, there's actually an answer for, because you only ask questions where you know the answer. What we don't communicate is that there are a whole lot of diseases and drugs and questions in medicine that no one knows the answer for. So we've got to figure out some way to insert that sort of uncertainty into medicine. And also, I think that leads to some humility and some recognition that we don't actually know everything that isn't currently in the medical curriculum, at least my experience with medical school curriculum. So I think we got to get across that there's a lot of the sort of mound of evidence that still needs to be uncovered. And then this idea of repurposing, I think that, I think we've got to get across that, like, when a drug is made for hypertension, it's not just a drug for hypertension, it's a drug that helps hypertension through a particular mechanism. And that particular mechanism may also be involved in something totally unrelated. And therefore we should be really creative about how it could be used.
And another question that I see is the FDA seems to be becoming increasingly aware that rare disease research is different, yet large medical centers have their own processes and systems that can be less nimble. Do you do any work with ethics boards to better understand rare disease research?
Oh, it's a great question. So I do not personally. I don't do any work in the realm of IRBs and ethics boards. I interact with our IRB and ethics boards a lot through the work that we do in Castleman disease, because we run a clinical trial of the drug I'm on, sirolimus, and we do a lot of research with human specimens. But no, I don't actually work with any directly. The work is critically important, and because you can't do good science unless you have well-informed patients who provide high-quality biospecimens and good data. So and clinical trials require patient engagement. So it's part of this ecosystem, but unfortunately, I have not actually been as involved on that side of things.
And a comment in the chat. Thank you for all your help. You gave my sister a second chance here in Canada.
Oh, wow. Oh, I love that.
Yeah. And here's a question. Did faith play a part in your journey, and how so?
Faith has been, I think everyone goes on faith journeys. And faith for me, I've had I would describe it as a roller coaster of a ride over the years. I mentioned at the very beginning of my talk, my mom died from brain cancer when I was 19 years old. And that experience of watching her diagnosis and then passing was really, really tough for me. She was like the most incredible person in the world. And she also was just like the most giving, loving, kind, perfect, human. And to watch her suffering really was hard for me in terms of sort of like fairness in the world and, belief that there's sort of, fairness. Because it just didn't seem fair at all. So that certainly, created some challenges. And then, of course, with my own health, a number of times where, if I had kind of trusted that it would all work out and had not acted, I think that I wouldn't be here today. And so for all those reasons, I would say that I'm on a roller coaster of a journey, but I do realize that it plays a really important role for a lot of people. And it certainly has played an important role for me at different times, but it's more of a roller coaster than a straight shot for me.
Thanks, Dave. And we have about 2 more minutes. So let's see, I'm gonna go ahead and take another question. I would imagine finding experts regarding very specific diseases is a laborious process. and what ways can we help make these connections more readily available, especially in low-income communities?
Oh, it's a great question. So, the problem is that there's only really two ways that I think that maybe three ways that I think are the easiest ways, the best ways to find people. First is, can you find a rare disease organization that maybe is kind of like a clearinghouse of good doctors? So one, Castleman disease, you go to the Castleman Disease Collaborative Network and we can help you find an expert. So look for that first. The next step down, I think, would be simple Google. Unfortunately, Google is not going to be as good at like, this person's really good, this person's not so good, but at least maybe that doctor has the disease written on their website that could maybe help. And then the third is actually PubMed, is kind of this like indirect sort of like, it's, going to quantify people who study that disease. And so you guys in your library know PubMed all too well. And so I think you could utilize that to get a sense for who are the doctors that are publishing a lot. And publishing a lot doesn't always mean you're a good doctor. I think that's important to know, but at least it's kind of the best of the worst sort of options that you have.
Great, thanks, David. Yeah, definitely. You can visit the library and we can definitely help with that. And one of the librarians I'm friends with on here also posted NORD, National Organization of Rare Diseases, as a resource. And I think we have 1 minute, so we'll have one more question if that's okay with you, David.
Absolutely.
On being respectful of your time. It's thank you for sharing your time. As a spouse of someone with a rare condition, osteochondroma, that has about 50% rate of passing to descendants, are there things that you recommend discussing or researching to prepare for a child's potential rare disease journey?
Yeah, that's really tough. I think that, a lot of my journey, obviously it's been my own health, but I've encountered so many families with children with rare diseases. And I don't think it was until I had children myself that I could, not totally, but somewhat sort of put myself in their shoes. And I think that it's just different, right? When it's not your disease, but it's, your child's disease. And I think it's really hard. And so being really thoughtful about that conversation and bringing in some professionals, not necessarily to be a part of the conversation, but maybe to help you with preparing for it. There are books on these sorts of topics. None that immediately come to mind that I can recommend, because fortunately I haven't had to have the conversation like this. But I do think that, I think doing your homework, whether it's reading books or connecting with experts who can guide you. I think that those sorts of conversations are important, because you only have a first conversation with your child once, right? And then every other time it's a follow-on to that. So I think it's important to be really intentional and thoughtful with it.
Great. Okay, well, David, thank you so much. This was a wonderful talk. And thanks everyone for your terrific questions today to really help keep the conversation going. Just great questions about rare diseases. And if you have any other questions or need any resources from the Health and Wellness Library, I'm always here to help, our dedicated team here as well. And also, before we leave, I want to announce our door prize. So we had over 80 people attend today. And from that, we have a winner, VCU Health's Alice Hay. So Alice, we will get in touch with you soon about connecting you with obtaining a copy of Chasing My Cure. And also, as I mentioned earlier, be on the lookout. We are also going to do a book discussion of Chasing My Cure, which I'm very excited about as well. So thank you all so much for attending today. And David, I just can't thank you enough. This was just so incredibly wonderful for our Rare Disease Day event, and we really appreciate you sharing your journey and everything that you're doing to improve the lives of patients with rare diseases. We really appreciate all that you've done. So,
well, thank you so much, Dana. I'm so happy to have the chance to be with you all today. And if you and your colleagues don't mind passing along some of the Q&A questions and chat questions before we close out, it's always helpful for me to have these things so I can make sure that the next talk I give like this, I can try to address some of those questions in advance. But like I said, these questions were so wonderful. I so appreciate the engagement. Dana could not have had a better fireside chat host than you for this. Only thing would have been better is if we were all in person in either Virginia or in Philadelphia. But truly, thank you all so much. I hope that hope you learned some things about rare disease today. I hope that Chasing My Cure and the lessons from it can be useful for you. So thank you guys so much.
Thank you, David.